Great. Thank you very much for the invitation, Joe and Manny. It's actually a real honor to be sharing the podium with two people on either end of this podium. So I haven't seen Pam for a while, but Pam Douglas taught me how to read echoes back in the day. And then on my left, Pradeep was actually one of my fellows who I trained. So I'm sort of on the spectrum here in between one of my trainees and one of my mentors. So it's
Pradeep,
nice.
you're my grandchild.
That's right.
Fortunate to. You do have a genetic company disclosure there, so maybe we can check that out. Yeah.
So good. So these are my disclosures, none relevant to this discussion. But we all know that dual antiplatelet therapy is important post-PCI, and we first sort of got a sense of this in 1996 from the initial ISAR trial, which basically demonstrated that aspirin and ticlopidine was statistically superior to a strategy of aspirin and heparin after the placement of coronary stents when you looked at the cumulative incidence of any cardiac or non-cardiac event. And that was back in 96. So soon after in 98, we also found from the STARS study that when you compared a strategy of aspirin versus aspirin and warfarin versus aspirin and ticlopidine, the rate at 30 days of death, MI, target lesion revascularization, and stent thrombosis was significantly lower in the aspirin and ticlopidine group. Some years later, we learned from the CURE trial that there was a 20% relative risk reduction with clopidogrel and aspirin compared to placebo and aspirin following non-ST elevation ACS. So just to give you a sort of sense of the data and the history of all of this, so we looked at the ISAR study, the STAR study, and the CURE trial, and this really started the trend, and since then, we've literally been drowning in studies looking at dual antiplatelet therapy in patients with CAD, post-PCI or otherwise. But really, it's the amalgamation of all of this data that has informed what we use now as our as a basis of clinical practice with the most recent 2016 ACC-AHA update on dual antiplatelet therapy. And then we have another document from our European colleagues that was published in 2018. And so what do they say? So here is the ACC document. And just to sort of clarify this, so this is acute coronary syndrome patients on the right, and regardless of therapy, medical, lytic therapy, any type of stent, bypass surgery, if you've had an acute coronary syndrome, the class 1 recommendation is for 12 months of dual antiplatelet therapy. So alternatively, if you're looking at a stable ischemic situation, there the discussion is a little bit different. So there's still this differential between bare metal stents and drug-coated stents. So after bare metal stents, it's 1 month, and after drug-coated stents, it's 6 months. But obviously, the discussion is not as straightforward or as simple as this table would suggest. Because what we're trying to do always with each individual patient that is in front of us is to balance the risk. And that is the risk of stent thrombosis, and there are a number of variables that go into predicting that, as well as the risk of bleeding. So how do we do that? How do we find that sweet spot where, along this spectrum of platelet inhibition, where we avoid the ischemic events and avoid risk of bleeding? So here is a hypothetical construct of a risk-benefit trade-off with prolonged DAPT as a function of thrombotic and bleeding risk. And along the horizontal x-axis, you see the bleeding risk increasing. And on the vertical axis, you see the absolute risk difference in coronary thrombosis and major bleeding. And looking at patients with the lowest thrombotic risk, for example, as you increase their bleeding risk scores, prolonged duration of dual antiplatelet therapy will cause harm. I mean, this is not rocket science, right? If a patient's at high risk of bleeding, keeping them on a dual antiplatelet therapy regimen for longer is going to be more harmful. So, but how do we understand these risks, and how do we understand what to do with the patients in front of us? So firstly, let's understand bleeding risk. So there are a number of factors that go into describing this. So whether the patient's on oral anticoagulation. Our female patients are at certainly higher bleeding risk, as are those that are older, those that may have hematological factors, those that have CKD, acute coronary syndrome, liver disease, PAD, patients with shock, and there may be some procedural factors that go into understanding the risk of bleeding, but all of these things will increase your risk of mortality. What about the risk of thrombosis? That's also something that we need to consider. So let me sort of digress for a second and present to you a case that is actually very current. This was a case that we were actually still dealing with, and he presented just a couple of months ago. So this is a 40-year-old man who 2 weeks prior to presentation was completely healthy. He was playing with his 2 kids out in the yard, no issues whatsoever. And then one day he presented to the emergency room with severe right upper quadrant pain and developed acute cholecystitis. So the ultrasound was done, there were gallstones, the diagnosis was made, labs were drawn, his white count was 1.4, hemoglobin 8.3, and a platelet count of 30,000. In addition, his troponin was drawn by someone, don't ask me why, and it was initially abnormal, but not elevated.
It was an ER.
But it peaked within a couple of, within 24 hours, it had peaked to 6.4. This was his presenting electrocardiogram. Sinus tachycardia, but nothing else too concerning. And here is his echocardiogram. So as Pam taught me, this is an apical 4-chamber view. The EF is reduced. The apex is not very happy, and it's clearly abnormal. So what do you do now? So you have someone who has acute cholecystitis, whose whose CBC is clearly abnormal, very concerning white count, hemoglobin, and platelet function, elevated troponin, with an echo that is also quite concerning. So he underwent an emergent ERCP and ended up with common bile duct stent. So that sort of took care of the acute problem, and his pain immediately resolved. And so now he's stable. He's not having any chest pain, but his troponin is 6.4 with the echo that I just showed you. So what do we do now? So he underwent a nuclear stress test because everyone was very concerned about sending him to the cath lab because of his platelet counts and so on. So his stress test, maybe not surprisingly, shows a large area of LAD ischemia. So now what? So as the hematologists are now on board, given his abnormal CBC, it now transpires that he has hairy cell leukemia. So within 2 weeks, so remember, 2 weeks prior to this, he was in his backyard playing with his 2 kids, and 2 weeks later, he has acute cholecystitis, a probable LAD issue, and hairy cell leukemia.
Lucky man.
So he's not having the best day. So what do you do now? How do you address this situation? So that algorithm I showed you for dual antiplatelet therapy really is sort of thrown out of the window a little bit. But so here are his options, right? So CT angiography, does he go to coronary angiography? Do you consider a bare metal stent versus a drug-coated stent in this guy? How do you manage the antiplatelet therapy for him? So hairy cell leukemia, I discovered, has a very, very good prognosis when treated, over 95%. But the chemotherapy involved with hairy cell leukemia will almost certainly reduce his platelet count to below 10, and there'll be a period of time when he's neutropenic as well. So just bear that in mind. Okay, so I'm gonna now go back to the rest of this discussion, and we'll come back to how this case resolved at the end. So so just to take one of these points here, so when this case was first sort of discussed, one of the issues that came up was, well, surely we need to go ahead and if he has a lesion, which is going to be likely, he needs a bare metal stent. So let me address that first. So the issue with bare metal stents is that, as we discuss the risk of thrombosis, we've learned that as our stent technologies have improved with better polymers, improved drug-eluting kinetics, and thinner struts, actually the second generation of drug-eluting stents have a much lower risk of stent thrombosis. Further, when you look at the North Stent study, which was a randomized trial of 9,000 patients, bare metal stent versus drug-coated stent, the rate of target lesion revascularization or restenosis was much lower in the drug-coated stent population. And so the question about bare metal stents should really be put to rest. And there was an interesting review by Antonio Colombo that addressed this, but suffice it to say that we should probably be avoiding the use of bare metal stents altogether. I don't believe there's a role for them anymore in the contemporary cath lab. And in addition, we have a number of trials showing to us that abbreviated duration of dual antiplatelet therapy is actually not harmful and is superior. So here's the leaders-free trial, which was a randomized double-blind trial of drug-eluting stent versus bare metal stent in almost 2,500 high-risk bleeding patients. In this trial, all patients received 1 month of dual antiplatelet therapy. And as you can see, when you look at both the primary safety and efficacy endpoints, which were cardiac death, MI, stent thrombosis, and the efficacy endpoint was target lesion revascularization, drug-coated stents were superior than bare metal stents. We have data from the senior trial, which looked at patients older than 75 years of age and showed superiority when a shortened duration of dual antiplatelet therapy was considered, favoring the drug-coated stent. So with that, how have the US and the European guidelines sort of reflected this? Well, as with all of our guidelines, there's a usual lag in adopting the most recent data. But currently, this is how it reads. So if you have a patient with stable coronary disease and high bleeding risk, the European guidelines don't really differentiate between type of stent, but you're looking at 6 months of dual antiplatelet therapy in a patient with stable disease and high bleeding risk. And in the US guidelines, it's similar. In acute coronary syndromes, both the US and the European guidelines give a 12-month recommendation. And for high bleeding risk patients, so the patient that I just described here would be an acute coronary syndrome, high bleeding risk, we're in this sort of gray zone. And this, I think, is where many of our patients fall. And this is why this sort of discussion becomes so involved and complicated. And so we have a number of studies, mainly non-inferiority in design, looking at DAPT duration. But the way that we might start thinking about this discussion is to try and use risk scores that have been validated for duration of dual antiplatelet therapy. So there are 2 scores that you can find online, the precise DAPT score and the DAPT score. And the variables that are used in the precise DAPT score are hemoglobin, white count, age, creatinine clearance, the history of prior bleeding. And basically, the score will then is ranged from 0 to 100, and a score less than 25 suggests that the bleeding risk is low, and so your duration of DAPT can potentially be longer. And the idea is similar with DAPT score. This was looking at 12 months versus 30 months. There are some procedural variables listed here to guide the risk of stent thrombosis as well. And these are what these calculators look like when you go online. And here, if you put in, so this is the precise DAPT score. This is a patient with a hemoglobin of 14 who's 65 years old, with a normal white count, a normal creatinine clearance, with no history of prior bleeding. This calculated score is 17. So you could consider a a longer duration without the risk of bleeding. Now, if you changed the age of this patient to 85, your bleeding risk score now goes from 17 to 27, and your risk is higher. So how do we put all this together and think about a decision-making algorithm for DAPT? So this algorithm here still has bioabsorbable stenting here. So I'm going to just take that out of the picture here because I think that's a completely different discussion. But I've already shown you what these guidelines show, but this doesn't really help us. And I think putting a number of these sort of features together, this is, I think, how we should be thinking about this. So the first thing to do when you're faced with the patient is to, number one, understand what is the patient's bleeding risk. And if the patient's bleeding risk is high, based on any of these scores, you might want to consider a 1-month duration of dual antiplatelet therapy in patients with DES. And so we're going to assume, for the purpose of this discussion, that bare metal stent is not even on the shelf in your cath lab. So that's out of the equation. So what about the clinical presentation? I think that then also guides.
Sorry, it's not.
It's a really long. It's going to spontaneously combust at any moment. So the next question is, what is the clinical presentation? So I think you can make an argument for 12 months of DAPT for all ACS patients, assuming the bleeding risk is low. And then I think it's important to characterize procedural complexity because I think that the more complex the patient from a revascularization standpoint, the longer the duration should be. And then after that, it's worth considering any residual risk to decide if you're going to continue for longer. There are a number of ongoing short-duration DAPT trials that most of the manufacturers are now sponsoring because I think we do have a large body of emerging data supporting much shorter duration of DAPT. All right, so finally, let me just conclude by telling you how this ended up. So you remember a 40-year-old gentleman, unluckily with acute cholecystitis, an ACS, and a diagnosis of hairy cell leukemia. He did end up getting a CT angiogram because, again, everyone was very reluctant to send him to anywhere close to the cath lab. He was found to have a very high-grade proximal LAD lesion. So again, a very sort of tricky situation. Here's what his angiogram looked like. So 95, 99% diffuse proximal LAD. Remember, this guy's only 40 years old, no family history of coronary disease. So we made the decision to move ahead with PCI of his LAD. And so he ended up with a single drug-coated stent to his proximal LAD, as you can see, with a nice final result optimized with intracoronary imaging. And he was started on aspirin and Plavix and continued for a duration of 1 month. So this was his precise DAPT score. So hemoglobin of 8.3, he's 40 years old, white count 1.4, he had a normal kidney function. His score was 25, which puts him in the high-risk category. So here was his follow-up echocardiogram. 6 weeks after PCI with a much improved ventricle. So we did go for that 1 month duration. Now he's actually, he had some issues with rectal bleeding because, so during this initial 6 weeks, he ended up getting some of his chemo. His platelet count did drop. He had a number of platelet transfusions during this, but remained on aspirin and Plavix. But he's now 2 months out from his LAD PCI and is now only on Plavix alone. So we've stopped the aspirin and he continues on Plavix and is doing fine and is making a very nice recovery from his hairy cell leukemia. So this is my last slide. It's clearly a necessary evil after PCI. it's very important to have a tailored patient-specific approach where you're weighing the risks of bleeding versus the risks of thrombosis. There are risk scores to guide decision-making in terms of the risk of bleeding. There may be other anatomical considerations to make to guide the decision on the risk of stent thrombosis. I've showed you a case that sort of puts all of these things together, but also sort of highlights the limitations of these risk scores and algorithms that cannot be applied to each of the patients that we see in front of us. I'm going to stop there, but if there's time during the discussion, I have a cautionary tale to discuss, but I'll stop there for now. Thank you.